Obese individuals face a paradox in cancer prevention. They are among the highest risk populations for developing several types of cancer, yet they are frequently underscreened. This represents a critical failure in early detection strategies, a missed opportunity that often leads to more advanced disease at diagnosis, worse outcomes, and increased mortality. While guidelines exist for age and risk-based screening, they often do not explicitly account for obesity as a major risk factor, and even when they do, those at risk may still fall through the cracks due to systemic, clinical, and social barriers. One of the most insidious obstacles is stigma within the healthcare system. Individuals with obesity frequently report feeling judged, dismissed, or shamed during medical visits. This can lead to a reluctance to seek care or delays in follow-up, especially for preventive services like colonoscopies, mammograms, or pap smears. When patients anticipate bias or have previously experienced disrespect, they may avoid appointments altogether. The result is a dangerous feedback loop. The higher the risk, the more crucial early detection becomes, yet the more likely it is to be missed or postponed. Logistical challenges also play a role. Diagnostic equipment, such as imaging tables or CT scanners, may have weight limits that make procedures difficult or impossible for patients with severe obesity. Some standard medical devices may not produce accurate readings or be physically uncomfortable. In clinics not equipped with appropriately sized gowns, chairs, or exam tables, both patients and providers may avoid thorough assessments. These practical shortcomings can create a subtle but powerful disincentive to perform routine cancer screening in larger-bodied patients. Clinical oversight further compounds the issue. Despite the well-established link between obesity and increased cancer risk, particularly for breast, endometrial, liver, pancreatic, kidney, and colorectal cancers, many healthcare providers fail to incorporate this into proactive screening plans. Obesity is often framed primarily in the context of metabolic conditions like diabetes or cardiovascular disease, while its carcinogenic implications are underemphasized or entirely overlooked. Without a clear clinical protocol to flag obese patients for earlier or more frequent screening, the default becomes inaction until symptoms arise, by which point the disease may be significantly advanced. Insurance coverage is another formidable barrier. Individuals with obesity are more likely to be uninsured or underinsured, particularly if obesity has limited their ability to work or if they fall into socioeconomic categories less likely to receive employer-sponsored health plans. Preventive screenings, though often covered under broad public health mandates, may still carry costs that are burdensome for those with high-deductible plans or gaps in coverage. Even when screenings are nominally free, ancillary costs, transportation, time off work, childcare, can make them functionally inaccessible. Meanwhile, public health campaigns rarely emphasize obesity as a standalone risk factor for cancer. Most efforts target the general population or focus on known triggers like smoking and family history. Obese individuals are often left out of targeted outreach and may not even be aware that their weight increases their cancer risk. This lack of awareness means they are less likely to advocate for themselves or request earlier screening, leaving the onus on a healthcare system that may not be equipped or willing to fill the gap. The cost of this neglect is high. Many cancers linked to obesity are asymptomatic in their early stages, but become lethal once they progress. Endometrial cancer, for example, is strongly tied to obesity but can often be caught early with appropriate attention to abnormal bleeding if providers are vigilant and patients feel comfortable reporting symptoms. Colorectal cancer, another obesity-related malignancy, is often preventable with regular screening, yet many obese adults remain unscreened well past the recommended age due to logistical or psychological hurdles. Correcting this oversight requires more than issuing new screening guidelines. It demands a shift in how healthcare systems, providers, and policymakers approach obesity as a legitimate and pressing cancer risk factor deserving of early and aggressive preventive action. It also requires dismantling the stigma and structural barriers that keep at-risk patients from receiving timely care. Until screening strategies are recalibrated to reflect the reality of obesity's cancer burden, the healthcare system will continue to miss the very people who most need protection. Early detection is one of the most powerful tools in cancer prevention, but it is only effective if it's applied equitably. Right now, it isn't, and lives are being lost because of it.